Today we'll talk about AUB. The dysfunctional uterine bleeding, or AUB-O in new classification. The dysfunctional uterine bleeding is defined as an abnormal bleeding from the genital tract in absence of any demonstrable local or systemic organic disease or endometrial pathology on clinical examination and routine investigations. Hence, AUB-O is a diagnosis of exclusions. It is less preferred term now and is called AUB-O. You can denote ovulatory dysfunction if you are using the farm-coin classification systems P0, A0, L0, M0, CO, EAI, ON, O1. Palm-coin classifications of AUB. It is seen in 10 to 15% of women. Okay. Previously, it is caused as DUB, that anovulated DOB and ovulated DUB. First one is anovulatory. It is more common and is responsible for 80 to 90% cases of anovulatory cases. It is characterized by irregular cycles, short cycles with scanty flow. It can be irregular cycles, short cycles with scanty flow or amenorrhea few months, followed by heavy bleeding, metropathic bleeding. Irregular cycles, short cycles with scanty flow, irregular cycles, short cycles with scanty flow, or amenorrhea few months, followed by heavy bleeding, metropathic bleeding. It is due to hormonal imbalance, due to alteration of HPO axis. It is seen more commonly in adolescence girl around the menopause, following pregnancy and during lactation in face patients. Okay. The pathogenesis of due to anovulation, there is unopposed estrogenic stimulation of the endometrium, causing persistent proliferation and hyperplasia of endometrium, followed by estrogenic uterine bleeding, which is painless, irregular, prolonged, lacking synchronization of normal menstrual cycle. What is the estrogen withdrawal? Because of estrogen withdrawal bleeding, endometrium followed by estrogen withdrawal bleeding. Due to anovulation, there is unopposed estrogen stimulation of the endometrium that lead to persistent proliferation and hyperplasia of the endometrial tissue, followed by estrogenic withdrawal bleeding. Estrogenic withdrawal bleeding, estrogen withdrawal, which is painless, irregular, prolonged, lacking synchronization of normal menstruation. The progesterone is responsible for secretion of prostaglandin F2 alpha and thromboxane, which cause vasoconstrictions. Hence, lack of progesterone causes deficiency of PGF2 alpha, because in anovulation there is, remember, in anovulation there is absence of progesterone. So there is no progesterone, so there will be no secretion of prostaglandin F2 alpha and thromboxane, which causes vasoconstriction. So hence both of them absence, that will relatively increase in vasodilator PG2 and prostacyclin, leading to painless and heavy menstrual bleeding. Okay, because of no vasoconstriction there is excess bleeding. Because of no PGF2 alpha, because of no progesterone there is no painless. Okay, this is the anovulated bleeding, AUB-O, that PCOS, then puberty menorrhagia is also a type of anovulated DUB, AUB-O, which is a threshold bleeding seen in adolescent. Anovulated AUB or ovulatory AUB-O. Threshold bleeding seen in adolescent due to unopposed excess estrogen in absence of progesterone. There is excessive menstrual bleeding. Continuous bleeding for many days can cause anemia and weakness. Okay. The prepubertal menorrhagia usually due to immature in the development of HPO axis, leading to their dysfunction and anovulation in the early part of puberty, that is 1 to 3 years after menarche. The pubertal menorrhagia usually due to immature development of hypothalamus-pituitary axis, hypothalamus-pituitary ovarian axis, leading on to the dysfunctions and anovulation in early part of the puberty. that is 1 to 3 years after menarche, usually with maturity of HPO axis. HPO axis matures and normal menstrual cycles are established. Sometimes puberty menorrhagia can also be due to blood dyscrasia like coagulation, bleeding disorders like von Willebrand disease, peripheral leukemia, and it can be due to hypothyroidism, genital tuberculosis in early stage of genital tuberculosis, hepatic disease, granulocytic cell tumor, feminizing of ovary can also cause puberty menorrhagia and need to be excluded. So what are the causes of puberty menorrhagia? The puberty menorrhagia mostly it is usually due to development of immature development of HPO axis onto the dysfunction, and that leads to inability in early part of puberty, that is 1 to 3 years after monarch. Usually with maturity the HPO axis will mature and normal menstrual cycle will be restored. Sometimes the puberty menorrhagia other causes like coagulation disorder like von Willebrand disease and bleeding disorder like peripheral leukemia, hypothyroidism, genital tuberculosis in early stage, hepatic disease, and granulocytic cell tumors, feminizing ovary can also cause puberty menorrhagia, and that should be, these are the causes to be excluded. Okay. Then patient presents with how they present with heavy menstrual bleeding, heavy regular painless cycles. Absence of dysmenorrhea is a characteristic feature of pubertal menorrhagia. Anemia can occur. Diagnosis is from typically the history, hemograms, ultrasound examination will be normal in most of the cases. The thyroid functions, taste and coagulation profile, bleeding time, clotting time should be done to rule out other causes of pubertal menorrhagia. Okay. Then management, how will management the unambulatory AUB? After ruling out the causes of pubertal menorrhagia, the treatment with tranexamic acid, cyclic progesterone therapy, or combined oral contraceptive pill is the treatment of choice. In that will 80% of cases will respond easily. So those patients who are presented with irregular cycle in early pubertal changes like 1 to 3 years post menarche, then after ruling out all the other causes like thyroid disorder, any coagulation disorder, any genital tuberculosis, or any other bleeding disorder, after that you can like any hepatic disease or any feminizing tumor of granulocytic cell tumors, peripheral leukemia, after ruling out everything, then treatment can be with the tranexamic acid, or we can give a cyclical progesterone therapy, or we can give a combined oral contraceptive pill therapy. 80% of cases will respond very good. If any cause is found, it should be treated accordingly. If it is detected hypothyroid, they can treat with thyroxine. Treatment of bleeding disorder or removal of ovarian tumors, hematinics are given. You can give anemia corrections. For severe anemia, blood transfusion may be given. Okay. Then metropathia hemorrhagica. It is a special type of DUB seen in perimenopausal women. This metropathia hemorrhagica, that is perimenopausal women, 40 to 45 years. The classical menstrual pattern is a period of amenorrhea, that is a period of amenorrhea for 6 to 8 weeks followed by continuous painless heavy menstrual bleeding. So the metropathia hemorrhagica, it is a special condition, special type of AUB, that is perimenopausal women, pubertal menorrhagia, perimenopausal women, PCOS patients. It is due to the hyperestrogenic conditions. Hyperestrogenism. The classical menstrual pattern is amenorrhea, period of amenorrhea for 2 months, like 6 to 8 weeks, followed by continuous heavy menstrual bleeding, painless heavy menstrual due to hyperestrogenism. In these conditions, uterus is bulky, uniformly enlarged with myohyperplasia. Myohyperplasia up to 25 mm myometrium thickness. Endometrium is thick, polypoidal, with formation of endometrial polyp in the lumen of the uterine cavity. And histopathology. Okay, these are the findings. Metropathia hemorrhagica. This is usually present in perimenopausal women, 40 to 45 years age. The classical symptoms is amenorrhea for 2 to 1 to 2 months, amenorrhea for 4 to 6 to 8 weeks or 2 months, followed by continuous painless heavy bleeding due to hyperhistiocynism. In this, there will be increased myohyperplasia like 25 myometrium thickness, formation of endometrial thick and polypoidal growth in the endometrial cavity, endometrial polyp formation in the lumen of the endometrial cavity. On histopathology, there is the cystic glandular hyperplasia. Cystic glandular hyperplasia, also called as Swiss cheese pattern of endometrial hyperplasia. This there in this how what are the things we can see? There is lack of secretory. There is lack of secretory endometrium because of absence of Cox-Q glands. Remember the Swiss cheese pattern. There will be lack of secretory endometrium and lack of secretory endometrium and absence of Cox-Q gland. Ovary may be cystic, like less than 5 centimeters, is to the absence of corpus luteum. Anovulations, because of anovulation there is no progesterone. Because of anovulations there is no corpus luteum formation. Okay. Ovaries may be cystic at less than 5 centimeter. Because of that, follicula is not ruptured, that it will form to cyst. And management of metropathic hemorrhagic is that of DUB, AUB, this progesterone therapy also. Then these are the AUBO. The AUBO can be PCOS, can be pubertal menorrhagia, it can be a pubertal menorrhagia with including other causes like bleeding disorder, thyroid dysfunctions, or hyperprolactinemia, or any like thick feminizing tumor of ovary, granulosa thicker cell tumor of ovary, and any other hepatic disease. Okay. Then metropathic hemorrhagia, that is in perimenopausal women, and that also because of hyperestrogenism. Then ovulatory or AUB, it is common in reproductive age group 20 to 45 years. That AUBO, that is anovulatory bleeding, is 80% of cases, and this the ovulatory AUB is 10 to 20% of cases of AUB. It is of two types. One is idiopathic ovulatory menorrhagia. One is idiopathic ovulatory menorrhagia. Idiopathic ovulatory menorrhagia. Exact cause is not clear, but lies in endometrium, with local factors being responsible. There is a relative increased production of vasodilator. What are the causes of ovulatory dysfunction? Ovulatory bleeding, DOB. It is common in reproductive age group like 20 to 45 years of age. It is accountability is 10 to 20% cases of DOB. It is of two types. First one is the idiopathic ovulatory menorrhagia. The exact cause is not clear, but it is mostly the things of local causes, local factor being responsible for the heavy menstrual bleeding. There is relatively increased production of vasodilator. And second is cervical. This is the cord specimens of uterus showing thick cord specimen of the uterus showing thick polypoidal endometrium in metropathica hemorrhagica. The micro photograph of the endometrium showing cystic glandular hyperplasia, Swiss cheese pattern in metropathica hemorrhagica. Okay. Then the first cause is idiopathic ovulatory menorrhagia. Second is luteal phase defect menorrhagia. The first is idiopathic ovulatory menorrhagia. The local cause, that is local cause already I talked about. The increased production of because of increased production of vasodilator, that is idiopathic, because of increased production of vasodilator like prostaglandin E2, prostacyclin, and decrease in vasoconstriction, that is prostaglandin F2 alpha, and thromboxane at endometrial level. Okay. In ovulatory DUB or AVO, that is idiopathic ovulatory menorrhagia, that is due to excessive vasodilatation compared to the vasoconstriction, because of increased vasodilatation like PGE2 and prostacyclin, decrease in vasoconstriction like thromboxane and PGF2 alpha at the endometrial level. The local causes, there is also associated with the dysmenorrhea and uterine cramp due to excess of PGF2 alpha. Remember, there will be imbalance between the vasodilator and vasoconstriction. The vasodilator like PGE2 and prostacyclin will be increase, and decrease in the level of vasoconstriction of prostaglandin F2 alpha and thromboxane at the level associated due to excess of PGF2. The treatment is by prostaglandin synthase inhibitor, mefenamic acid, and antifibrinolytic drug. because here the main things is the increase for vasodilatic prostaglandin analog, so we have to inhibit with the mefenamic acid prostacyclin. So vasodilatic decrease bleeding, mefenamic acid how will act, the mefenamic acid with the non-steroidal anti-inflammatory drugs, what they do, they will inhibit the as cox inhibitor, so that the prostaglandin will not form, the vasodilator will not form. So there will be for antifibrillary drugs also can use mefenamic. There will be decreased free vasodilator, prostaglandin E2 and prostacyclin. The luteal phase defect menorrhagia, there is reduced production of the progesterone in luteal phase and alteration in ratio of prostaglandin. What happened in luteal phase defect? Luteal phase defect, the LPD menorrhagia, because there is a reduced, there is some production of progesterone, but there is reduced production of progesterone in the luteal phase, and the alteration in the ratio of progesterone due to lower progesterone level, menstruation occur earlier with shorter cycle, polymenorrhea, and there is irregular ripening of the endometrium due to progesterone deficiency. Treatment is by progesterone therapy in luteal phase, norethistron, medroxyprogesterone acetate 5 to 10 mg thrice a day from day 15 to day 25 for 3 to 6 months. Okay. In luteal phase defect, there will be reduce in the production of the progesterone in luteal phase and alteration in the ratio of the prostaglandin, that due to lower progesterone level, there will be menstruation occur earlier with a shorter cycle, that is polymenorrhea. There is irregular frequent cycles, there is a irregular ripening of the endometrium and due to progesterone deficiency. Usually the treatment is progesterone therapy in luteal phase, progesterone therapy in the luteal phase, that is in the day 15 to day 26 you can give, then you can go for luteal bleeding, norethistron or norethistron or medroxyprogesterone acetate 5 to 10 mg thrice TDS for day 15 to day 25 for 3 to 6 months. The progesterone therapy can also be given from day 5 to day 25, 3 to 6 months. So you will it. It can be given day 5 to day 25, it can be day 15 to day 26, day 25. Okay. Yeah, you can give day 5 to 20 or day 15 to 25, 5 to 10 mg, 5 to 25 mg, 5 to 10 mg TDS. Okay, diagnosis of AUB. History taking. Detailed history taking is very important in case of AUB. To identify the cause, underlying cause of AUB, thorough menstrual history is corrected, especially age of menarche. First thing, age of menarche. Second thing is date of last menstrual period, timing and amount of bleeding, intermenstrual bleeding is there or not, length of menstrual cycles, history of any associated symptom like fever, weakness. Why you are asking fever and weakness and all? Urinary PID, bowel anemia, bowel urinary symptoms, especially due to pressure effect like in fibroid uterus. History, any symptom of fever, weakness, pressure symptoms like bowel urinary symptoms, passes of clots, product of conception product, any so pregnancy complications, any pain need to be asked. Detailed history should be also asked about medicines taken by the patients, medication history to be taken by the patients, especially use of NSAIDs, anticoagulations, drug causing hyperprolactinemia, including herbals, Ayurvedic, homeopathic medications. They can also cause AUB. The intermenstrual bleeding may go in favor of gynecological disorder like polyfibroid malignancy. Any associated with dysmenorrhea with AUB goes to the favor of structural abnormality like polypetenomyces, leiomyoma, malignancy, infection and pregnancy complications. Raised local prostaglandin can cause both AUB and dysmenorrhea. Then after history taking, we go for a general physical examinations is performed to identify the finding released related to etiology like porphyria can cause porphyritic spot and skin of AUB. Presence of obesity, signs of hyperandrogenism you can see for hirsutism, acanthosis nigricans, obesity, PCOS, towards which is false BP, pallor, anemia seen in AUB, jaundice, edema, significance, lymphadenopathy, any thyromegaly, heart, chest, and breast examination, abdominal examination for hepatosplenomegaly, abdominal masses. Then after general physical examination, you go for a gynecological examination, including local examinations, speculum examinations, bimanual examination, cervical growth, polyp, uterine size, shape, tenderness, any adnexal mass, uterine size, shape, any adnexal mass, induration, fixity. This fibroid and adenomyosis and ovarian mass can be made out. One should also examine if there is a vaginal bleeding or should be ruled out urethral rectal bleeding, as they can present as a cervical cytology also taken at the same day. Speculum and vaginal examination can be omitted in adults in non-sexually active. Rectal examination is performed for any rectal pathology. Adolescent glands or vaginal examination not performed. Investigation laboratory test. The UPT should be done for fast serum metastasis should be done in all cases of pregnancy. Complication like miscarriage, ectopic pregnancy, hydrated mole can cause serious hemorrhage, resemble AUB, miscarriage, ectopic, hydrated mole. Then complete hemogram is the cell hemoglobin to be the severe rate of bleeding and anemia. Some women may become severely anemic, may require emergency treatment including blood transfusions, blue blood including platelet count, blood indices, MCS is also useful. Bleeding time, clotting times, coagulations profile including partial thrombosis, VT, hepatitis, especially useful in puberty energy to rule out born liver disease, bleeding disorder like perfura, thyroid function test, especially TSS in relations, human male history of suggestive thyroid dysfunctions, hypothyroidism associated with the liver and renal function test. Ultrasound examination, usually transvaginal ultrasound is performed due to its better resolution. It is non-sexually active women. Transabdominal ultrasound is full blood is performed. It can diagnose structural causes like polyp, adenomyosis, glioma, malignancy. Ultrasound is also particularly suited postmenopausal bleeding is more than 4 mm thickness. Indicate further testing with cystoscopy or endometrial biopsy to rule out endometrial cancer for endometrial thickness less than 4 mm. Investigation can be avoided even unless there is other high risk factor for malignancy. There are no definite cut available for premenopausal women, but normal appearing endometrial thickness less than 10 mm in women with AUB don't want invasive testing low risk women. However, in high risk chronic aneurysm, diabetes mellitus, obesity, tamoxifen, and shifting is needed. 3D ultrasonography color pulse Doppler may demonstrate endometrial lesion better can show endometrial artery venous malformation as well as multiple irregular branching malignancy. Saline infusion sonography or sonohysterography in which ultrasound is performed. After the introduction of saline into the uterine cavity, it identifies structural endometrial submucosal lesion causing AUB, endometrial polyps, submucosal hemolytic indifference between intracavity endometrial polyps, submucosal intramural lesion. Ultrasound examination, usually transvaginal ultrasonography is performed due to its better resolutions. In non-sexually active women, transabdominal ultrasound with full bladder is performed. It can diagnose structural causes like AUB, like polyps, adenomyosis, glioma, malignancy. Point classification: ultrasound is also particularly suitable for post-menopausal bleeding where an endometrial thickness of more than 4 mm indicate further testing with hysteroscopy, endometrial biopsy to rule out endometrial cancer. For endometrial thickness less than 4 mm, the invasive testing can be avoided unless there are other high risk factors. There is no definite cutoff or loop for premenopausal women, but normal pregnancy. Transvaginal ultrasonography, large endometrial polyp. Endometrium with endometrial thickness less than 10 mm in women with AUB does not warrant invasive testing in low risk women. However, in high risk women, chronic aneurysm, diabetes mellitus, obesity, tamoxifen use. Chronic aneurysm, diabetes. Ultrasound, 3D sonography, color pulse Doppler may demonstrate Endometrial lesion better can show endometrial lesion in malformation. Saline saline infusion. Saline infusion sonography or sonohysterography, in which ultrasound is performed after the introduction of saline into the uterine cavity. It identifies structural endometrial and submucosal lesion causing AUB, endometrial polyp, submucosal melanoma. It can be differentiated between intracavital endometrial polyp and submucosal intramural lesion. Submucosal and submucosal melanoma. However, it has a limitation. It is not superior to TBS, especially in menopausal patients. CTs, MRI in not routinely performed in AUB but may be useful in suspected adenomyosis and malignancy. Histoscopy. In this procedure, 3 to 5 mm rigid histoscope is inserted into the uterine cavity using saline or glycine or CO2 as a distension medium. It allows visual inspection and magnification of endometrial mucosa. Any focal lesion also allow the directed biopsy from the suspected area under direct vision, and also allow complete removal of small focal lesion or polyp in the same sitting. In this procedure, 3 to 5 mm rigid histoscope is inserted into the uterine cavity using saline or glycerin CO2 as a distance medium of the visual inspection and magnification of endometrial mucosa. Visual inspection and magnification of endometrial mucosa, any focal lesion, and also allow directed biopsy from the suspected area under direct vision, and also allows complete removal of a small focal lesion polyp in the same sitting. The main advantage of detection of the intracavital lesion like polyp and myoma, which may be missed in transvaginal ultrasonography. Endometrial sampling can be done. Some clinicians consider histoscopy is a primary tool for all cases of AUB. However, it is invasive, expensive, technically more difficult as compared to ultrasound and endometrial sampling. There is also risk of infection and perforation. There is also theoretical risk of peritoneal contamination of cancer in endometrial cancer through the fallopian tubes, but overall prognosis does not worsen. Culture can be performed on cervical, so if there is cervical child discharge or lesion, it is test for chlamydia and gonorrhea. Cervical cytology. If not already performed, cervical cytology pap smear should be taken in all cases of cervical intraepithelial neoplasia of cancer. In obvious cervical lesion, colposcopy or cervical biopsy. If there is no lesion, you can go for pap smear. Or if there is visible growth or lesions, colposcopy guided cervical biopsy can be performed to rule out cervical cancer. Endometrial sampling for biopsy, it is the most important investigation AUB. Especially after 40 years of age, it provides tissue specimen from endometrium for definitive pathological diagnosis. It is essential post-menopausal bleeding, especially if endometrial thickness is more than 4 mm. In case of high risk for endometrial cancer like obesity, PCOS, or hypertension, diabetes, ACOG recommended 40 for all of AUB older than 40 mm. History of on-opposite exposure like PCOS, obesity, uncontrolled hypertension, persistent AUB despite medicine. The method of endometrial sampling, Karman's cannula number 4 size is often used, especially in minor operation theatre, outpatient basis department without local anesthesia or painkiller. It is very cheap procedure. The device or Bhavara aspirator or people can be used. The sample is aspirated and sent for 10% formalin solution for histopathological examination. Both endometrial hyperplasia with or without atypia or endometrial cancer can be diagnosed by Karman's by endometrial sampling. And then dilatation, it is less frequently done because these days becoming more invasive, more painful procedure, less accurate. It needs dilatation of the cervix, which is painful. Curettage cannot be, curettage almost whole and is performed, but being blind procedure, it can miss some area when it is done under intravenous sedation or local anesthesia. Summary of diagnosis: out of all the stages, transvaginal ultrasound is most useful modality followed by endometrial sampling. In most cases, it will be the diagnostic algorithm will be so. The management depends upon the age of the patient, the type of the AUB, and the setting, severity of the bleeding, desire, fertility status. Some managed acute AUB, some women, especially severe endometrial menstrual bleeding. Severely anemic, dehydrated, they require immediate fluid resuscitation. Fluid resuscitation, intravenous IV fluid in the form of dextrose, saline or saline in hemocell, blood transfusion, severe hemorrhage. Control of hemorrhage, conjugate equine estrogen, Premarin 25 mg intravenous every 4 hourly for 3 doses. Can control acute uterine bleeding followed by oral Premarin combined for maintenance dose. Alternately, for less acute hemorrhage, Premarin 2.5 mg orally 6 hourly. Combined estrogen and progesterone or contraceptive containing 30 to 50 microgram estradiol can be given every 6 to 8 hourly per day, 7 days followed by once daily for control bleeding. After control bleeding, 8 TDS for 7 days. Tablet method is progesterone acetate 10 mg every 4 hourly, then every 10 mg for 4 days, then every 6 hourly for 4 days, every 4 hourly for 4 days, then followed by 10 mg 6 hourly for 4 days, then 10 mg 8 hourly, 4 6 8, 10 mg 8 hourly, 4 3 days, 10 mg 12 hourly, 4 hourly 6 hourly, 8 hourly 12 hourly, 10 mg plus 4 days, then 3 days, then 2 weeks, 4 days for 10 mg every 4 hourly for 4 days, 10 mg every 6 hourly for 4 days, then 10 mg 8 hourly for 3 days for 3 for 2 weeks. IV tranexamic acid 10 mg per kg every 8 hours is given till bleeding become less, followed by oral tranexamic acid 1 gram per day, 1 gram thrice a day for 5 days. Management of chronic treatment of anemia is by giving hematinic iron with folate, other multivitamin without calcium, vitamin D supplementation, ferrous sulfate gluconate given in dose 100 mg twice a daily. Lifestyle modification with weight reduction, diet, exercise in case of PCOS, related AUB. Medical treatment is the mainstay treatment. The non-hormonal antifibrillary agent tranexamic acid is an antifibrillating drug which reversibly binds with the tyrosine binding sites on plasminogen. It is particularly useful in AUB and due to endometrial causes like AUB in which fibrillary activity of endometrium is increased. Evidence-based medicine previously efficacy, it has been reduced the blood loss bleeding by 40 to 50% is a drug of choice for AUB. It is given in a dose of 2 divided dose, 2 tablets 650 mg, total 2 tablets 650 mg 3 times a day for 5 days during mens. It can also be given as 1 gram 2 tablets twice a day, 2 tablets of 500 mg twice a day, 1 gram TDS or 650 mg 3 times a day, 2 tablets of 650 mg 3 times a 1.3 grams 3 times a day or 1 gram 2 times a day. 650 वाला tablet आ रहा था. If it is 650 mg 2 tablets 1.3 gram thrice a daily for 5 days, 1 gram thrice a daily. It has been used by FDA is no effect no other blood coagulation parameter. Safe drug, it provided the history of thromboembolic disease, should not be combined with combined pill. NSAIDs and endometrial bleeding medicated for prostaglandin, NSAID, prostaglandin synthesis, helping to reduce bleeding, especially AUB endometrial cause. They inhibit cyclohexane enzyme, dysphenomenal acid dose of 500 mg 3 to 4 times a day during menstruation for 5 to 7 days. Dose by acid 25%. There are also usually AUB ovulatory so they are only moderately but they can also combine with tranexamic is better effective over NSAIDs. Patient abnormal uterine bleeding, this is detailed history and taking and examination, treatment EPT positive, ultrasound to diagnose the miscarriage, ectopic pregnancy and hydrated for more, manage the specific condition, negative, complete blood count, bleeding, clotting factor, coagulation disorder, TSS, swab smear, profile of serum prolactin. If it is normal, if it is abnormal, manage as per the disease, thyroxine, LEAP, ACI and hypothyroid. If it is acute AUB or chronic AUB, if the severe anemia, hospitalization, blood transfusion, transvaginal ultrasound, endometrial biopsy, treatment as per disease. Chronic AUB, high risk for cancer, ultrasound see for normal or abnormal thickness, observation, if normal observation or medical treatment, tranexamic progesterone, abnormal endometrial biopsy, abnormal report, cancer treated as cancer, normal report or benign pending, medical treatment with tranexamic and progesterone, effective, continue, treatment is ineffective, surgical management of hysterectomy can be done. Then endometrial biopsy, abnormal report treated as the cancer, normal report of benign pending, medical treatment with the tranexamic and progesterone, treatment effective, continue, treatment is surgical management of hysterectomy. The diagnosis: if a patient does not need contraception, does not prefer hormonal treatment, try medical treatment. Mefenamic acid 500 mg thrice daily during menses, reassess after 3 months. Patient much better condition, continue indefinitely inside LNG IVs. Tranexamic acid, mepenamic tranexamic acid 1 to 1.3 gram thrice daily during menses. Reassess for up to 3 months. Patient better after uncontrolled. Continue indefinitely inside LNG. Patient not relieved. Need contraception also. If they initially should ask for hormonal treatment. The normal contraception combined oral contraception pill review after 3 months, review every 3 months. If it is better, continue for few years. If not effective, surgical treatment. Long acting progesterone, if it is better, continue for few years. If not effective, surgical treatment. LNG IUS insertion, review after 6 months. If better, continue LNG IUS. If failure, surgical 6 months. Endometrial ablations, surgical treatment or hysterectomy, vaginal laparoscopy or abdominal. More platelet inhibiting action like aspirin. Aspirin, ibuprofen, naproxen, capillary fragility inhibitor like ethymisalate given a dose of 500 mg 3 to 4 times a day alone with mepenamic acid. Tranexamic is given by some clinician but not very effective, especially if given alone or not recommended. Diapel vascular protective agent dose 300 3 to 4 times a day during menstruation have also been used, has been found to be effective in some study. Hormonal treated project, they are very effective for AUB. Non-hormonal हो गया. अभी हार्मोनल ट्रीटमेंट प्रोजेस्टेरोन, they are very effective in AUB, both ovulatory and anovulatory are also useful in AUBE. Non-ethistone has been better homocystetic effect but is androgenic. Ethistone given dose of 5 to 10 mg thrice daily for day 5 to day 25, 21 days of each cycle for 6 months or to 1 year. Alternatively, medroxyprogesterone 6 to 5 to 10 mg TDS per day 5 to day 25 can also be given. They are also useful and effective in metropathic hemorrhagic. Progesterone given only in luteal phase day 15 to 25 may be effective in ovulatory AUB but should preferably given day 5 to day 25 for better efficacy. Reduction in blood loss by 30%. Day 5 to day 25. Also, reverse endometrial hyperplasia side effect of common are mood changes. The progesterone effect mood changes, weight gain, bloating, headache. Injected progesterone report medroxyprogesterone acetate tape 150 mg intramuscular can be used but is less popular due to irregular bleeding and amenorrhea. Progesterone intrauterine LNG IUS system. Miranite contain 52 mg 11 hour gestrol and release 20 microgram per day locally at endometrium. With atrophy the endometrium reduce the menstrual blood loss by 75 to 95% within 3 months of use. It is a first line management. First line management for AUB bleeding. It is particularly reproductive age women with AUBE who need contraception wish to retain fertility. Its drawback: high cost, irregular bleeding which may continue for 1 to 2 months. It contraindicated in abdominal uterine cavity, distorted cavity, breast or genital malignancy, liver disease, reproductive tract infections, breast genital disease, breast genital malignancy, breast malignancy, reproductive tract infections, uterine cavity distorted. LNG IUS is proven to more effective in decreasing menstrual blood loss than NSAID given during menses or oral progesterone given for 21 days. Combined oral pills in various RCT. LNG IUS also has the higher quality of life score compared to the other treatment. LNG IUS has been found to have equal efficacy to endometrial ablation and hysterectomy. The incidence of hysterectomy over AUB has been decreasing with the LNG IUS. In Western countries, drawback, however, in some study up to 46% of women underwent hysterectomy after LNG IUS due to lesser satisfaction or effect. It is more difficult to insert, take 2 to 3 months for full effect. Amenorrhea occurs 25% of women, which is not preferred in young women. 46% underwent hysterectomy. Combined oral contraceptive, they are one of the most effective and popular treatment. A combined oral contraceptive is one of the most effective and popular treatment of AUB. Reduce blood loss by 50%, 50% reduction, 95%, 75 to 95%. AUB reduce blood loss by 50%. They also treated associated with dysmenorrhea, provide added contraception. The mechanism of action: endometrial atrophy, decrease prostaglandin synthesis, decrease endometrial fibrinolysis. Usually combined pill containing 30 microgram progesterone estradiol with 75 microgram progesterone, levonorgestrel, given cyclically from day 5 to day 25 per cycle for 3 to 6 months. Can be prolonged in endometrial hyperplasia cases. They are particularly useful in AUB but can be used for AUBO also. Any OC pill including Malayan available free of cost in government hospital can be used. Other drugs like androgen, GNS analog or male excipients entropona. Danazol is a derivative of 17-alpha ethylene testosterone. It creates a hypoestrogenic, hyperandrogenic environment in the endometrium, leading to endometrial atrophy, reduction in the menstrual blood loss by 50%. It may even give amenorrhea. It is also given dose 100 to 200 mg daily. It is mainly used for AUBA but can be used in AUBE. However, it has a significant androgenic side effect: weight gain, only skin acne, oily skin acne. Not usually used AUB but is reserved for second line drugs, short-term use, prefer surgery. Gestrinone is a synthetic derivative of 19-nor testosterone, 17-ethynyl testosterone, 17-alpha ethanyl testosterone. 17-alpha ethanyl testosterone is gestrinone is 19-nor testosterone, has similar effect and side effect like danazol, 2.5 mg orally twice weekly. GNS analog leuprolide glycerin. This drug can cause pituitary downregulation, amenorrhea. They are given in a dose of 3.75 mg leuprolide acetate or 3.6 mg glycerin. 3.75 leuprolide, 3.6 mg glycerin subcutaneous every 28 days, every monthly for 3 months. Although highly effective, they cause amenorrhea, menopausal side effect like hot flashes, very expensive, dryness of vagina, osteoporosis. They are also very expensive, usually for short term, especially prefer surgery. Sent from danazol, gestrinone, GNS analog, leuprolide, glycerin, or mil selective estrogen receptor modulator, which is usually used an oral contraceptive. It is also used in AUB in dose of 60 mg twice weekly for 3 to 6 months. 60 mg twice weekly. 60 mg twice weekly for 3 to 6 months. Surgical last resort should be used when the 6-month medical treatment has failed. All the types of surgery, both conservative and definitive, should be explained to the patients. Decision of type of the surgery is made taking into consideration the age of the patient, parity of the patient, fertility, desirability, and patient desire to keep uterus. Conservative surgery like dilatation is mainly used for diagnostic purpose to rule out the endometrial cancer, endometrial hyperplasia, tuberculosis. However, it is often used in emergency in heavy menstruation for temporary and quick relief of acute bleeding resistant to hormonal treatment. By removing the thick end endometrium, arrest heavy bleeding. It may also effect in incomplete miscarriage, endometrial polyp. However, it is not effective method to control AUB. Endometrial ablation resection technique. This technique attempt to make permanently remove resection, destroy the uterine lining. The indication of the endometrial ablation: AUB refractory to medical therapy, young women with AUB who want to preserve their uterus, women of AUB with high surgical risk of hysterectomy. Medical therapy failed and surgical risk for surgery and preserve their uterus. Contraindication of the endometrial ablation: pregnancy, women wanting to preserve fertility, pregnancy, want to preserve fertility, acute upper genital tract infection, gynecological malignancy, women at high risk for endometrial cancer, large uterus with distorted cavity due to fibroid adenomasis, postmenopausal women, intrauterine device in situ, post-uterine surgery, classical cesarean delivery, myomectomy with cavity opening. The indication of the endometrial ablation is AUB related to medical therapy. Those are high risk for surgery. For women with AUB, those who want to preserve their uterus, pregnancy, women with active surgical infection, preserve fertility, gynecological malignancy. Those who are having high risk for endometrial cancer or large uterus with distorted cavity due to fibroid adenomasis, postmenopausal women, intrauterine device in situ, post-history of surgery, classical cesarean section, myomectomy. Endometrial ablation is performed in post-menstrual phase when endometrium is thin, easy to resect and bled. Post-menstrual phase, when the endometrium is thin and easy to resect, can be performed by first and second generation technique. The first generation technique like trans-cervical dissection of endometrium using electrical diathermy, roller ball electrocoagulation, endometrial laser ablation using ND ablation. First generation में TCRE trans-cervical dissection of the endometrium using electrical diathermy, roller ball electrocoagulation, endometrial laser ablation using ND ablation. This technique are performed through hysteroscope using lysine as distance media. Preoperative and preparation of endometrium usually done with danazol therapy or GNS analog or beta ablation. They are usually performed under general anesthesia. The entire endometrium is at the receptor electrocoagulate with lower ball or laser. The disadvantage of endometrial ablation that is more difficult to perform. First generation is difficult to perform. They need training with long-term learning. Usually general anesthesia is not a risk of performance. First generation technique. Trans-cervical dissection of the endometrium using electrical diathermy, roller ball electrocoagulations, endometrial ablations, and ablation. This technique performed through hysteroscope using lysine distance media. Preoperatively preparation and GNS analog or danazol to make the endometrium thin. Performed under general anesthesia, endometrium like resected or coagulated. Trans-cervical dissection of the endometrium or coagulation by roller ball or ND or laser. They are more difficult to perform. Complication of fascination.